final like a study guide like online?
That's where we're getting ready to talk about the study guide.
Yeah.
So your final study guide, I finally making a decision on it, is only going to be rhythm strips, and that's what we're going to review today and Wednesday. So you will have 50 rhythm strips, short answer that you will need to identify for your final exam. Okay, that's the key part of the exam or of the content of the course that I want you to have. And you guys are doing better than some of the classes that I've had, but there's still some weak areas. Yes, sir.
No cardiology stuff, no stroke stuff.
50 EKG rhythm strips is what you'll have. Okay. All right. So what we're going to do is we're going to kind of go through this, and I'm recording the lecture so you can go back and take a look at it as well. Let me get my little highlighter here in case I need it. So all of these should be considered what you see up there, whether you see hash marks or not at the top. They should be considered to be, if you see hash marks, count within the hash marks. If there are no hash marks, is considered to be a 6-second strip. All right. So tell me, what is your rate in this EKG?
100.
How much?
80.
2, 3, 4.
80 to 90.
Okay. So I would tell you 80 to 90, we're okay. Okay. Rhythm. Okay. Do you see P waves?
Yes.
Do the P waves look upright?
Yes.
Good. Okay. Tell me about the PR interval. Okay. So the PR interval does look normal. Does every P wave have a QRS?
Yes.
Okay. Does every every QRS have a P wave?
Yes.
All right. And what do you notice about the width of the QRS complex? Okay. And what is the normal width of a QRS complex? How much? Under 0.12. Yep, you're exactly right. Good. All right. So, what is this? What is this EKG then? Yeah, everything is normal on this EKG, so it has to be normal sinus rhythm. And this is the thing that I want you to do, is to make sure that you're going through and asking all of those questions that we just went over as you are identifying your rhythm strips. A word of kind of reminder to you is that sometimes some of y'all are making, and I don't say this out of being critical, but you're making really, really stupid mistakes. So, for example, when you got a rhythm that is a first degree block, you're not identifying the underlying rhythm. Almost always, not always, but almost always, that underlying rhythm is going to be one of two rhythms, which is going to be what? Bless you. Normal sinus or sinus Brady. Okay, normal sinus or sinus Brady. Same way with your ectopics, with your PACs, your PJCs, your PVCs. Make sure that you're telling me what the underlying rhythm is for that as well. Now, again, as you've seen, I've given you extra credit when you go into greater detail and you tell me, particularly like with PACs, PJCs, or PVCs, oh, it is the third and the sixth complex in on there, or particularly with PVCs, are they polymorphic or are they monomorphic? Is this couplets? Is this triplets? Is whatever else is going on in there? So again, kind of remember in that regard. Good. Tell me your rate. Okay. So let me ask you a question. Can this be normal? Can this be sinus tach? No. Why not? Yeah, the rate is too fast. Rate is too fast. So we're able to eliminate that right away. Okay. Rhythm. Yeah, it looks pretty regular to me. Okay. Do you see P waves? Say it again. Not really. I mean, you could make an argument that maybe there's a P wave. Let me do this in here, or in here or something. But again, the faster the rhythm, the faster the rate, the less likely that you're going to see P waves. Okay. Now let me ask you a question. What is that waveform right there that we're looking at?
Which one?
This one.
T wave.
Why are we seeing T waves in if we can't see P waves because of the rate?
They're buried in it.
Say it again.
So they're buried in it.
Maybe.
Well, and also SVT supraventricular. It's not coming from the normal pacing site.
Very good. You are correct. But again, why are we seeing T waves and no P waves?
Repolarization is more electricity.
I'm having trouble hearing today, so say it a little bit louder.
Repolarization takes more electricity than the P wave.
As a result of what? Yeah, you're on the right track now, Matt. The ventricular repolarization. Remember, size matters. So the ventricles. The ventricles are much larger than the atria, and the left ventricle in particular makes up about 75% of the heart. And so that's why we're seeing those larger waveforms in there, okay? So we don't really see P waves, therefore we can't really identify what? No PR interval, okay? So now, what do you notice about the width of the QRS? Okay. So somebody tell me what that rhythm is. Yeah, that's SVT. Now let me ask you a question. From a hemodynamic perspective, with a rate of 190, what are you going to see in your patient? Now, you won't be tested on this on your exam, but again, remember, this class is building you up so that you can go into advanced cardiology in the fall. But what would you most likely see in your patient?
Flushed, sweaty.
Why? You're right. Tell me why you're right.
Because the heart's working hard.
So the heart is working harder. So we've got that oxygen workload demand. What else is, let me put it this way, what else is not happening with a heart rate of 190?
Perfusion. Not enough perfusion.
Why? Yeah, you're right. Again,
Preload.
not enough preload. So again, when the heart gets to beating really, really fast, there's not enough time for the chambers of the heart to be open to accept enough blood in. So as it goes up and it hits about that 140 per minute mark, your cardiac output will drop dramatically. Why? Because of a reduction in preload. Good job. Very, very good. All right. So this one, we're going to kind of go backwards. Your rhythm, the regular atrial rhythm, and you have an irregular ventricular rhythm. The rate, the atrial, is that of the underlying sinus rhythm. The ventricular varies depending on the number of impulses conducted through the AV node, will be less than the atrial rate. P waves, sinus, they look good. The PR interval is not consistent. It varies. It'll progressively lengthen until a P wave isn't conducted, which basically means that the P wave happens, but there's no QRS afterwards. And then we have this pause after the dropped QRS. When you do see a QRS, its width is normal. What is that rhythm? Close. Type 1. Now remember, okay, one of the things I want you to remember, let me make sure I get the right marker, okay, is that when you're looking at your blocks and I have identified it, look at the PR interval, okay? And if it is consistent or inconsistent, first degree, second degree type 1, second degree type 2, and third degree. So when we're looking at first degree, remember the criteria for a first degree block is what?
Greater than 0.2 second PR interval.
That, and what else about the PR interval? It's constant. So it's greater than, not greater than or equal to, greater than 0.20 seconds, and that PR interval, if you measure it across that 6 second strip, it doesn't change. It is consistent, okay? We see the exact same thing with a second degree type 2. What happens in a second degree type 2 as far as the PR interval is concerned?
Consistent.
And what else? So the PR interval is consistent. It could be long or it could be normal. What else happens? There's a drop QRS. Yeah, so there's a drop QRS. So with first degree block, second degree type 2, that's where we see consistent PR, consistent PR, consistent PR, PR, or P, no QRS. Now, we get over here to second degree type 1, much just like we've got the description up here. Now what we see is that PR interval starts out somewhere. It could be already elongated and gets longer, or it can start out as normal and gets longer. And then we have a P wave and no QRS. So that's an inconsistent PR interval. With third degree block, what's the hallmark as far as your PR interval for third degree? It's very variable. Yeah. What else? Yeah, it's disconnected. The P waves up, or the atria is up here doing its thing, sending out P waves. They're never getting down to the ventricles. So the ventricles have to kick in and do their thing. And because they contract at a lower rate, you're going to have more Ps than you are going to have QRSs. But the PR intervals literally kind of look like an accordion. It's all over the place. All right? Just remember that. This will help you because, like I said, many times you look at a rhythm, you go, that's a heart block. Is it? And most of the time, y'all are really pretty good about identifying first degree heart block. Sometimes you forget the delayed rhythm. That's okay. But many times you go, okay, that's a heart block. And much like you did just now, Sydney, it's kind of like, is it first, secondary type 1, type 2, or third degree? If you use this up here, this will help you to get more of them right. All right? Right. Okay. Rhythm. Regular or irregular? Regular. Do you see P waves? Do the P waves look upright? Oh, okay. All right. What do you notice about the PR interval? It's variable, right? Okay, it's variable. What do you notice about the width of the QRS? It is normal, okay? So what is this rhythm? So what is wandering atrial pacemaker? Tell me, somebody tell me what's happening with WAP?
There's different pacemaker sites in the atria, firing at different times.
So let me ask you a question then. Why do we have this guy right here? Is that coming from the atria? Ooh, you guys are good. Which tells us what is causing that? Where's that one actually coming from? Which is called the
Valve.
starts with a J. Junction. Okay. So the AV junction is actually at the very bottom of the right atria. Okay. So you're exactly right. These are coming from the atria. This is coming from the junction. How do we know it's coming from the junction? Why is it inverted? What makes it inverted? So now, say it again, Sydney. So remember, okay. So up here is the SA node. I think I heard you right. AV node is down here. The normal conduction pathway of the heart is to go this way. Okay. When it's going down towards this lead, that gives us a positive deflection of our P wave. If our P wave is down here, now guess what? It has to go up this way. That's going away from the positive lead, and as a result, that gives us an inverted P wave. Okay? Most of the time, not anything to be worried about, but again, within that right there, that is very important. Now, again, what is the difference between WAP and MAT? That's the only difference. That is the only difference, okay? Anybody not understand why this is WAP? Sir?
WAP, like 2 or more, or 3 or more?
3 or more. Now remember, here is your first P wave, so that would be number 1. This one looks pretty similar, okay? But now this one is very, very different, okay? So now we've got 2 different ones. The other thing that we want to look at right here is that, is this PR interval the same as pretty much this PR interval?
It looks similar.
It's similar, but it looks like to me that this PR interval is just a little bit wider, which tells us that that impulse over here, okay, come back, right there, is coming from somewhere else other than where this impulse comes in. But then again, we've got this one right over in here. So that's a third different looking one. And then we've got this one here. This one's more rounded. These are all tend to be pointed.
So a normal P wave still counts as like a different P wave.
Yeah, so what you do is you look at your very first P wave here, okay? That's number 1, okay? And then we look at this, let's see, this one right here, it's inverted. That's number 2, all right? And then we come over here and we don't have 1, okay? That's 3, and then we see this one right over in here. It's nice and rounded. That's 4. All you got to have is 3. Good question. Good question. Anybody else? Yes.
So we know MAC and WAP, the difference is the rate. Instead of tachycardia, but it's the same 3 plus arrhythmia as the MAP. So how do I keep myself from confusing WAP if it's, for example, sinus arrhythmia? What's the...
If it's sinus arrhythmia, the P waves will not be different. With sinus arrhythmia, basically what you're doing is you're seeing the R to R intervals get farther apart when the patient takes a breath in, and when they exhale, the R to R intervals come closer together. So that's when the R to R intervals get farther apart, that's slowing the heart rate down. We take a deep breath in, we put pressure on the vagus nerve, it slows the heart rate. When we exhale, we take the pressure off of the vagus nerve, it speeds the heart rate up. That's why the R to R intervals would come closer together. Your P waves in sinus arrhythmia will look the same. All right? Good questions. Anybody else? Okay. Rhythm, irregular and chaotic. You can't measure its rate. There are absent P waves, wavy, irregular deflections seen varying in size, shape, and height, representative of quivering of the ventricles instead of contraction. Deflections may be small or large. PR interval is not measurable, and there is no QRS complex. Name that tune. Say it again. Not torsades. VFib. Okay, VFib. Now, VFib is a type of ventricular tachycardia, not ventricular fibrillation. If you name torsades polymorphic VTAC, I'm okay with that. It's just another name for it. Most of the time people call it torsades, but if you call it polymorphic VTAC, you're okay. The difference between torsades and VFib is, number one, you can see QRS complexes. They're wide, they're tall, and they're bizarre looking. But with VFib, all you see is a little squiggly line down at the bottom. Okay. All right. Right.
Wait, going back to what you said about
Yep.
it would just be like the top of the QRS would be the same, right?
That's in monomorphic VTAC. So if you got monomorphic VTAC, let me draw. This is monomorphic VTAC. So if you are looking at this and you're going, okay, is that just VTAC or is that torsades? If you can draw a line across the top and that line is fairly straight and across the bottom, that's just simple VTAC, okay? With torsades, we see this. So basically think of it as kind of like the waves of the ocean. And that would be torsades or polymorphic VTAC. Okay? Anybody else? Right. Okay. Rhythm. Okay. You see P waves? Do they look upright? Okay. What do you notice about the PR interval? Constant and normal. What do you notice about the QRS? So what is this? This is sinus tach. You see the difference that we can see here with sinus tach? Remember, this rate is 130. The one that we had earlier was 190. With 130, we're able to pretty easily see the P waves that are in there. Now, for whatever reason, this converts over into SVT. Did I say VTAC? I didn't mean VTAC. SVT. When we saw SVT earlier with 190, we couldn't see the P waves. But if this converts over to SVT, now those P waves will have a tendency to will disappear. It doesn't mean that they're not there, but what it does mean is that they're getting embedded in the T wave. Questions?
If it's just sinus tach, then it'll still have P waves.
I will tell you, almost always it will have P waves. Now, it is possible that you could have a... Okay, let me ask you a question, Sydney. You bring up a good question. You're a smart lady. What if this were up here with this rate and you didn't see any P waves? What would you call it? Say it again. What would you help her out? What would you call this? Not SVT. It's not fast enough for SVT. No, you don't see any P waves. Junctional or accelerated junctional tachycardia. Yeah. Or accelerated junctional rhythm. Okay. Last question here. What's up with this little up and down roller coaster thing here? Patient's moving. Patient's probably moving. It's artifact. Maybe he's in the back of an ambulance and the ambulance is moving down the road. Okay. Excellent. Rate. 60. Rhythm. Good. P waves. There aren't any P waves, right? No P waves, no what? No PR interval. What do you notice about the QRS? It is wide. Yeah, it is wide. What's this rhythm? Say it again. It's a pacemaker rhythm. Now, for the bonus points, is this a single chamber or a dual chamber? How do you know? You've only got one mark. Okay. If it was a dual chamber, you would see what? And what else would you see? P waves. So if it was a dual chamber, we would see hash mark, P wave, hash mark, QRS. Okay. If you just tell me this is a pacemaker, awesome. You're getting all the points. Okay. You tell me if it's a single chamber and it's like this, or if you call it a ventricular pacemaker, that's okay too, because it's stimulating the ventricles. I'm okay. I'll give you some bonus points. If you tell me if when it's a dual chamber and it's a dual chamber and you see both of them, you'll get some bonus points there. Okay. Excellent. The rhythm is regular. The rate is 100. It says to 160, but it should be 140. P waves are normal in size, shape, and direction. You got one P wave for every QRS complex. The PR interval is normal, and the QRS is normal. What is that rhythm? Sinus tachycardia. Okay, that's why I got to adjust that. I've got 160. It's too fast. Yes, sir. Anything over 140 is considered SVT. You will see different numbers in different textbooks, but just for consistency in here, anything greater than 140 is considered an SVT. It's coming from above the ventricles because we're going to see a narrow QRS, but we can't call it a sinus tach because it's just too fast. All right? Right. Not too fast to count. It is fast. I will give you that much. How much? Okay. Rhythm? Are you sure? Would you not say that these are pretty regular and that these are pretty regular? So you're still going to call it irregular?
Yeah.
I hope you do. Yeah, okay, regularly irregular. So there's a pattern to it. But it is irregular. Okay, good. So, P waves. You don't see any P waves? I mean, really? Okay. So there are some and then there aren't some. What do you notice about the PR interval when you do have P waves? Okay. And what do you notice about the QRS complexes of all of them? Okay. So what is this? This is PSVT, and P stands for what? Paroxysmal, and that means? What does PSVT mean? Close. Close. So paroxysmal means you see it either start and or stop. So if we were to take this rhythm right here and just kind of turn it upside down, it would start out slow and then speed up. With the way it is right now, it starts out fast and it slows down. So either direction. If it starts fast and slows down, PSVT. Starts slow, builds up to fast, PSVT. Rate.
140.
Fast. Rhythm. It is a little irregular. You're good. We're going to explore why that is here in just a minute. Okay. Do you see P waves? Are they upright? Are they all upright?
Yeah.
Okay. All right. What do you notice about the PR interval? It what? It varies. What do you notice about the QRS? So, ladies and gentlemen, boys and girls, what is this rhythm? MAT. Look here. Okay. So the first thing we do is we're looking at this, and right over here is our first P wave. That's it right there. Okay. Look how close it is to the QRS. So that's P wave number 1. There's P wave number 2. It looks entirely different. There's P wave number 3. It looks different. That's all the evidence we need. You can go all the way through and look at the different P waves if you want to, but as soon as you hit 3, that's all that you need. Yes?
It looks more like atrial flutter than
With atrial flutter, you will see sawtooth waves that are consistent, because atrial flutter means you have one area, one cell in the atria that is firing consistently, and it's periodically it will let every second, third, or fourth going through, unless we have variable conduction, and in which situation what you're going to do is those F waves, those flutter waves, are going to be consistent. As you see right here, this right here is actually a T wave, and if this were a flutter wave, this one would have to be pretty much the same size. All right, any questions on why this is MAT? Yes.
Why does it kind of seem like on the left side of the strip, it kind of looks like there's a T wave and then possibly another P wave, and then I guess that could just be the negative deflection when the QRS begins, but it almost looks like another P wave. It just looks like there's a lot in between the complexes, where I thought MAT there was still one P wave and one T wave for each complex, even though they were irregular with different morphologies.
So now remember, with MAT is a precursor to atrial fibrillation. All right, and so in atrial fibrillation, somebody tell me what is the pathophysiology? What's happening in an AFib? What is? The atria is, okay, which it shows up on our EKGs as having multiple little fibrillation, little F waves. If you're looking at this one right here, I would agree with you, okay? This is our T wave, but we've got this and we've got this. To me, what we're seeing in here is the early formation of atrial fib. Similar right here, that's our T wave. Now we've got this and we've got this. But now look here. There's our T wave, and look, one P wave. Now it changes back over in here. And explain to me, if this is our T wave, why does it look that way? Why does it look kind of like the humpback of a camel? No, not biphasic. This is another P wave that's embedding itself on the T wave. And again, what we would want to do is we would want to watch this patient for AFib to continue to develop in there. So again, AFib and MAT go really, really closely. AFib is usually going to be fast. MAT is always going to be fast. Yes?
If it looks like the one you just pointed to, does that indicate that the atria is starting to quiver?
Mm-hmm.
Starting to turn into
Yeah, so what actually is starting to quiver back here because we've got two impulses. They both look different, which tells us they're coming from different points in the atria. So it's actually starting all the way back over in here. Good observation. Any other questions on that? This is good. All right. Your rhythm. The atrial is regular. The ventricular is regular. The rate, the atrial is that of the underlying sinus rhythm. The ventricular rate is going to be about 40 to 60 beats a minute. Okay, could be slower. For your P waves, you'll see normal sinus P waves with no relationship to the QRS. They could be in the QRS, could be in the ST segments, could be in the T waves. The PR interval, ding, 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 it varies. It is not constant in any way, shape, or form. The QRS could be normal if it's happening at the level of the AV node, but most of the time it's going to be wide. What is this rhythm? This is third degree block. This is third degree block, okay? Third degree block, life-threatening rhythm or not? Absolutely. All day, every day, okay? All day, every day. All right, look at this one. Don't let it throw you off. Are you sure it's asystole? Or is it fine V-fib? Say it again.
So that's got to be ACEs.
You're right. It's got to be asystole.
If there's electrical activity, it's like it's not real.
Yeah. So as you're looking at this, this is actually, we see with asystole, we're thinking, just a nice little solid flat line. This is all artifact in here. Okay. Artifact meaning it could be the patient's sweaty. It could mean that there is hair there. Could mean that there's a lot of adipose tissue on the patient's chest. This is definitely not electrical activity. So this is indeed asystole. Okay. Asystole is a terminal rhythm. Less than 1 to 5% people survive this, especially. Put this in the back of your brain for those of you going into the sequence, which the letters are going out. So they started going out this morning. Some of you are going to need some additional courses, but we're going to work with you on those if it's available. But especially if you see this in trauma, these patients are not going home. Okay, they're not going home. Right. Rhythm. Okay, ventricles are regular. What about the atria? Atria is regular too. Okay, what about the PR interval? Wide. Okay, so it is wide, or what? I mean, look at what about this right here? Is that P wave wide? I mean, that PR interval wide? No. Okay, so it varies. QRS width. It is wide. What is this rhythm? This is third degree block. Remember, third degree block, you have no consistency or no pattern in the PR interval. Travis. That is ST depression. We will learn more about what ST depression means in advanced cardiology. Now, here's the thing to remember, just a little bit of tidbit of coming attractions is we're only seeing this in one view. In order to conclusively identify whether this is actually ST depression, we got to run a 12 lead. And we got to see it in 2 or more views that are looking at the same part of the heart. Now, none of that will be on your exam, but most definitely, if you were to look at this and tell me that that's ST depression, I'd give you some bonus points, basically because this is your ST segment and it's below the baseline. All right? Rate. Okay. Rhythm. It is irregular, right? Okay. There's some periods of regularity, but there's something in there that's making it irregular. P waves. Do you see them? Okay, they're there, except when they're not. All right. What about the PR interval? So the PR interval wouldn't be regular. It's either normal or abnormal. The PR interval is abnormal?
Well, I mean, normal with P waves, yeah, but there's no P waves then.
Okay, so if there's no P waves, there's okay. Got you there. Got you there. Okay. What about the QRS complexes? They're normal, except when they're not normal, right? So what is this rhythm? Say it again. Normal sinus rhythm with PVCs. Now, for the bonus points, are these unifocal or multifocal? These are unifocal. These are unifocal. Okay. Everybody understand why they're unifocal? Yes, sir.
Maybe it's just the quality of the script, but I thought those would be pacemaker spikes.
These over here
Uh,
or this?
I thought it was pacemaker.
yeah, those look very
Where?
similar. Like
On the-
all of those spikes,
These right here?
especially the last one, it looks really narrow.
I wasn't thinking the QRSs. I was
This right here?
Yeah.
on the wide. No, I was thinking on the wide
Oh, the
thing.
QRS.
Oh, over here.
You see that little spike coming up off of it?
So with a pacemaker spike, it is going to be considerably larger and straight up and down than your following QRS or P wave. So if you look at this really closely, and you're right, could be potentially the quality of the thing, but as you can see, this actually goes up and then it comes down. A pacemaker spike would instead basically be that. So this it would be normal sinus rhythm with PVCs. If you were to tell me the PVCs are number 2, 3, 4, 5, 6, 7, and number 8, you get extra points. If you tell me they're unifocal, you get extra points. Okay. But again, remember with ectopics, PACs, PJCs, PACs, you got to tell me the underlying rhythm in order to get all of the points and to qualify for any bonus points. All right. Next one. Rhythm is regular, can be slightly irregular. Rate is 140 to 250 a minute. There's no P waves associated. Well, that tells you the answer right there. PRM is not measurable, and the QRS complex is wide. That, ladies and gentlemen, has to be what? That has to be VTAC. Now, let me ask you a question. Tell me again, how do you identify the difference between VTAC and torsades? Changes of what?
If it's consistent, like when I say the morphology, I mean if the size and shape of the
Excellent
wave is the
answer.
same, it's a VTAC, and if it's changing throughout the thing, it's torsades.
Okay, excellent answer. Very good. Very good.
I have trouble identifying the difference between V-fib and torsades sometimes because I'll look at V-fib and I'll think it's torsades.
Okay. So, let me once again display my incredibly deficient artistic skills here. With torsades, there is some organization. Okay. Here's torsades. And here is VTAG. Couple things to look at. I'm sorry, thank you, VFib. Excellent, thank you. Your amplitude is always going to be smaller in VTAG. Okay. Amplitude, remember that's the vertical size of what you're looking at. So your amplitude here up and down is going to be smaller with VFib than it will be with VTAG. or torsades. With torsades, we do have a pattern that repeats itself. With VFib, you're not going to see, and this is not a really good representation of VFib because you could say, well, that's just really, really fine torsades. But the size of the complexes that you're seeing there is what makes the difference, and there is no pattern whatsoever. Okay? Anybody else? All right. Bless you. Rate. Say it again. Rhythm. P waves. PR interval. Not regular. Normal. Now, once you identified it as normal or abnormal, you can tell me if the PR interval is regular then, which means it is consistent, okay? Or if it's variable, all right? What about your QRSs? What is that? If everything's normal about it, it's got to be normal sinus rhythm. All right? Good. Right. Rhythm. P waves. PR interval. QRS width. What's the only thing that keeps us from being normal sinus rhythm? So therefore this is sinus bradycardia. What is the big issue with sinus bradycardia? Say it again. How do you know? Is it possible that somebody could have this rate and be in perfect health? Yep. If any of y'all are long distance runners in here, it's a good possibility that your heart, when you're resting, or pretty much when you're sleeping, is maybe that slow. Obviously, I don't run for much of anything. You can tell that. My heart rate gets that slow. Y'all need to do something. Okay? So again, how do we know if this is a normal or not? We assess the entire patient. Okay? We assess the entire patient. All right, so we've been going for about an hour.